Nyanza is one of the 8 provinces of Kenya. Kenya, as a country like any other developing country, has got a huge burden of HIV/AIDS.
We are dying because of AIDS. Our eyes are full of tears. We are tired of this disease.
Because of HIV, it has one of the biggest burden of orphans.
The world has changed. We are dying because of AIDS. In the past, we lived in peace. But now the world has changed. We are dying because of AIDS. Our eyes are full of tears. We are tired of this disease. Thank you.
The problem in this part of Kenya, particularly in the rural areas, is that children are being looked after by perhaps grandparents or other family members once their parents have died that are essentially unable to provide for them properly.
KOP has been able to build a feeding center where the orphans walk in and out to enable orphans to have food so that they can stay in schools because their parents or their grandparents that they're staying with cannot afford to provide them with food.
And the centre as a whole is equipped with a resource centre, a hall for taking the meals and a proper kitchen block for cooking the meals. Between here and the road, which is about 3 or 4 kilometres, you could have 3 or 4 of these centres if you wanted. Most of the schools in this area, and there are many schools in this area, the orphan population in the schools is anywhere up to 1/3 or 1/2 of all students, and so the need is enormous. Another thing KOP is involved in is orphan sponsorship in schools, and in fact construction of schools in the area, and we've been very fortunate to be involved in the building of a primary and secondary school not very far from here at all. Some of the students here attend those schools. It was in 2004 that we sent students over from Nottingham, Reading and King's universities to help with the construction of those schools, and up to half the students in those schools are orphans and are supported locally here. One thing we've been aware of for a very long time is the very large number of street children living in Kisumu town.
Most of them are orphans. Most of them ran from home because they didn't have anybody to take care of them.
Because my father died when I am 9 years old. And after that, then I decided to come here in the street because I don't have someone who can stay with me very well, who can pay for me fees, buy for me clothes.
There's a major drug problem. The glue, most of them they sniff the glue. The girls are raped, some of them are involved in prostitution.
You find the time is getting worse and the policemen are harsh with us and we are being beaten here, so the life is very cruel.
KOP has been providing meals for those children over the last year.
Madam.
So when the children come, they come from as early as 2 p.m. So they come and they start queuing. And when we start serving, the first to come are the first to be served.
But what we wanted to do was to develop that programme further to not just encompass providing meals, but also healthcare and specifically education, and helping to get those children back to their rural homes, reintegrated into their communities and off the street. And actually with some local groups, that's what's now happening. way we are able to operate all these projects, and the real key to Kenyan Orphan Project, if you like, is our student groups. That's how it started, and it's something we're still very proud of. And every summer we have groups of students from the UK, principally from Nottingham Medical School, King's Medical School and Reading University, coming out, raising funds and actually physically participating in these projects. KOP was started in 2001, essentially by chance meeting.
A group of medical students from Nottingham University decided that they wanted to spend their summer in Kenya. So they came to widows and orphans which agreed to work with them in developing a program for Kenyan orphans in Kenya.
And then in the summer of 2002, brought our first group of medical students over to Kisumu to help with the building of what is now Port Florence Community Hospital.
So the ultimate aim here is to build a massive ward as an adjunct to Port Florence. It's going to include a male ward, a female ward and a paediatric ward. The original Port Florence is going to be targeted at the slightly more rich of the population, and they'll be subsidising the patients that can come here.
So we're able to treat orphans, people connected to project work, other people in the community, able to treat them with very good quality service that they wouldn't receive at the government hospital for essentially no cost. The other day, we'd taken the KOP group out to the feeding programme that we're running as one of our projects out in one of the rural areas, and we were alerted at that time to 6 of the children, 6 orphans who were in need of medical care. And at that point we were actually able to transfer them over here to Port Florence. One of the boys that we had been alerted to out at the feeding centre, there was concern that he might have a dislocated hip.
And he's been having pain around the hip pelvic area. So after the x-ray, the doctor discovered that he had a double fracture. And it seems like probably due to negligence or something, no medical attention was taken. So the bones have healed, but not correctly.
That's what happened.
If you weren't able to bring the children to this hospital, then they wouldn't get the medical attention that is required because they do not have proper access to medication back in the village there.
This actually will be kind of, if we need to do dressings or minor procedures, it will be in there. We've got 3 doctors' rooms, and then they'll move along from the doctors' rooms to the pharmacy. So chairs, big chairs, lots of chairs out for the doctors' waiting area.
Because they're about to fall out.
And the door, this will be the main pharmacy. And then to complete the kind of linear camp model, if you like, there is the exit. The group we've got out here at the moment are doctors and nurses from the southwest, principally from Bath, but from all over the southwest. And they've all come out here to participate in a programme of medical camps, free medical camps in some of the rural areas around Kisumu in Western Kenya where we are, where poverty, deprivation, HIV and AIDS prevalence is a real problem. The facility was perfect and we were able to put in that kind of line.
Susie and I have worked together before, but mostly, like the last time we worked together, it was to do a ward round, and we would like leave in the morning to see maybe 5 or 6 people up the ward, and we'd kind of take us most of the morning. And now we're maybe going to see 1,000 people, and maybe not. So it's very scary.
Okay, so tomorrow we need a full work of tents. On Friday we need full work of tents.
I'm a little worried about today. I'm expecting to see hopefully a lot of children and not too many adults, just because I haven't done adult medicine for quite a while. I guess we're going to see a lot of malaria,
vomiting, typhoid.
Possibly some HIV, some TB, a lot of diarrheal disease, dehydration.
And worm infestation.
Yeah. But see how it goes, see what happens.
Yes, true. If you look at the background, you see lots of kids. The adults are not here. Reason being, these are mainly orphans. The adults are dead.
Had a huge turnout. There's been well over 1,000 people, far more than we expected to see, and we've actually managed to see most of them, which was one of my fears, that we wouldn't just get through the sheer numbers in time.
It has been very, very successful because we've managed to see everybody who came to be seen. You can see we are here because the few who are left, we are determined to clear with them. We don't want to leave anybody unseen.
Well, I hope that perhaps they might have a more regular access to general practitioner care, because that's what we've been, general practitioners. I need a lot better language. I've learned a lot from the doctors. I've seen my first diagnosed case of AIDS, just straight new, children quite sick and some difficult problems, a new child who's blind.
No one's well, and everyone needs to be seen by a doctor, and many of them probably haven't been seen for ages, so it's really nice just to be able to, you know, see these people and maybe do something decent for a change.
Even though all the children are scared of us because we're white and they haven't seen a white person before, so they start crying whenever we try and do anything to them. It's quite funny.
I've not seen so much malaria or as many infected wounds. I'm stoked, so I can't stop talking too quickly.
Well, the donations to allow us to have a free medical camp are absolutely vital. And for them to be given this sort of quality service and this sort of medication free, they feel as if somebody really does care for them.
Many people have responded and they have told me that they have been treated and they can go back laughing anyway. They have appreciated it anyway. Thank you.
There's just a baby that's just turned up right at the end of the clinic day who's very, very sick. I would say in these resources possibly not salvageable, but we must take her to the hospital as quickly as we can. Has already been to a traditional healer. It's probably been lingering like this for a long time out in these places with no access to healthcare, and that's the problem that we see here, so we'll just do the best we can. This child was seen in our camp at about 11 o'clock this morning. We referred to her urgently. It's now 10 past 4. From 11 o'clock this morning, 10 past 4 now, she's lying out here and hasn't been seen. And she's really sick. And Julie actually personally took her to the health clinic here, excuse me, where we've just gone now, 6 or 7 hours later, and she's still lying outside on the concrete, yet to be seen by anyone. And the baby that we also brought here, the doctors essentially, or the clinical officer that was working essentially just wasn't interested. Too busy, and in fairness, another 3 or 4 babies who look exactly the same sat waiting in the very long queue, and there's only, I suppose there's only so far you can push it in terms of trying to bump. Why bump this one to the front of the queue above 4 or 5 others that have been waiting since 9 o'clock this morning in all likelihood? So just because we have a bit of space and obviously have personal dealings with these 2 children, we're going to transfer them to town and take them to the district hospital.
Unfortunately, the little girl we brought in the other day sadly died yesterday, as we found out when we went into hospital this morning. Her hospital stay and the tests cost the equivalent of about $40.
So the grandmother was left with a bill essentially that encompassed a 50 shilling fee for registration and to actually buy her notes, the book that her notes were going to be written in, a 350 shilling bill for all the tests that she had, a 1,600 shilling bill for essentially bed and accommodation in the hospital, despite the fact that she was sharing with 2 other children at times in that bed. And then there's an extra cost that thankfully the grandmother didn't incur, but if Ruth's body had been kept in the hospital for any amount of time, then she would have faced a 2,200 shilling release fee, which is essentially a totally unmanageable amount of money for somebody in that grandmother's position. Personally, I feel comfortable that we did try to provide her with the right care. We didn't know what was wrong with her exactly, and she may have had a very reversible condition which we could have tried to prevent. As it happens, she was probably very, very ill, more ill than perhaps we suspected, and perhaps the most appropriate thing would have been to let her die at home peacefully with her family. And that's something we have to battle with in our consciences and take on a case-by-case basis and just hope that we make the right decisions.
Gracias.